Hi, my name's Tori and I wish I knew more about blood products.
Hi, my name's Letitia. I wish I knew more about taking care of myself when starting shift work.
Hi, my name is Lydia. I wish I would know more about how to work as in a team and solve conflict.
Hello, welcome to Five Things, the nursing podcast from the Royal Brisbane and Women's Hospital. My name is Liz Crow.
I'm Jesse Spur, and this is a podcast by, for, and with the amazing nurses and health professionals in our corner of the world. We hope to connect with a global community as we move from surviving to thriving. Welcome to Five Things.
Hello, my name is Liz Crow.
And I'm Jesse Spur.
Welcome to another episode of Five Things Nursing. And today we're excited to welcome Liz Knox, who is a CNC for Gynaecology Oncology here at the Royal Brisbane and Women's Hospital. And she's going to talk to us about gynaecological cancer. Welcome, Liz.
Oh, thanks for having me, Liz and Jesse.
Awesome to have you here. We'd love to get to know a little bit about your nursing journey. We've been talking off air that you've just finished your master's. Congratulations.
Yes, congratulations.
Let's take it back a few pegs from there and tell us where it all started and how you got into the work that you're doing now.
So I've always loved doing cancer nursing. I've done cancer nursing for about 20-something years. I don't want to give my age away. My grandfather had prostate cancer when I was a teenager, and that's, I think, why I ended up where I've ended up. But I've always worked in medical oncology until the last couple of years when I've been coordinating surgical oncology statewide services. So cancer is my jam, which you can't say to people outside of health because they think you're weird. But cancer is really where I've always been and where I love to work.
And just for curiosity, what was the sort of focus of your master's project?
It was on burnout and compassion fatigue in cancer nurses post-COVID. So we know that during COVID, patients couldn't get to their primary healthcare physician or they couldn't get to their general gynae clinics or whatever across the state, and that the cancers that we have seen diagnosed in these ladies or in patients across the board are much more advanced. And so that's brought with it a whole lot of new issues for us cancer nurses. So, I was looking at burnout and compassion fatigue and probably just trying to find legitimacy in why I was so tired at the end of the COVID experience. So, yes. Burnout.
So, of course, you did what every good nurse did. When you're exhausted, you take on some extra study.
Right.
Yeah, well done.
Awesome. And I just wanted to pick up, there's obviously a tendency for gendered language in an episode like this. So we are going to be talking about anatomy and largely anatomy and some physiology around gynecological cancers. We're talking about female sex assigned at birth organs essentially here. That's still quite commonly parochially referred to as women's health. So we'll be taking the shortcut a little bit of that, but it's intended to include all people who are female sex assigned at birth.
Yeah, that's great. Thanks, Jesse.
Okay, so let's get into it. Your number one is, what is gynaecology?
So gynecology is essentially the study of women's diseases or the science of reproductive organs. So the science of women. And the reason you would see a gynecologist is there's a range of reasons. One might be disordered bleeding, so bleeding that doesn't sort of fit the normal pattern. It might be something to do with puberty and changes to the body during that time. It might be infertility or contraception or menopause, which is in the media at the moment a lot, to people talking about menopause. So you might see a gynecologist for any of those reasons. And it's really critical as women that we know our bodies really well, because the first thing that a specialist is going to say is what's normal for you. And if you don't know, it makes it a little harder to treat. Not impossible, but a little harder to treat. So knowing our own bodies and what is usual for us is critical for us women. And I guess that leads probably a bit too soon, but into the next point, which is that if you notice something that's unusual about your anatomy, your cycles, then that's when you would definitely go and see a gynecologist. So we know that the symptoms of gynecological cancers are vague and often really difficult to determine what they are compared to, say, menopausal symptoms. So some changes in bowel habits, some bloating, needing to wee all of the time when usually you go once a day. I mean, you need to drink more water, but if you suddenly need to go to the toilet all the time, or you feel full after eating, a few chips or something, then they would be reasons that's abnormal. That would be something that would be different for you. So that's when you go and see a gynecologist to talk about that.
Right. So she's doing me out of a job here because that is your number 2.
Sorry.
That's all right. That's good. That's a great segue. So your number 2 is this symptoms of gynecological, not just cancer, but gynecological difference or something that would be used as a trigger or an alert. Do you think that women on the whole I still think there's a lot of embarrassment. We've said it on here before that people find it hard to say the word vagina. People find it hard to talk about their periods in public or with their colleagues. I notice I have suffered from endometriosis since I was 14 years old. I find that at least, these days, at least it's people know what it is. It's much more common. But how often do you think women are still hesitant to go and talk to their doctor or even talk to their partner or their friends or family around gynecological symptoms?
Yeah, absolutely. It's probably our biggest thing is that patients even are worried about coming to see a gynecologist and what they're going to think of them when they have their legs up in the stirrups. There's definitely an embarrassment, and it's something that we just don't talk about. And I think that we've just got to get over that, because it's 50% of the population have a bleeding every month. And so we need to be talking about that more. And I think that as women, we need to be really mindful of taking note, I guess, of what's going on in our bodies so that we can then determine when it's not normal. If your cycle is 46 days every single time, well, then that's fine. If you go and see a doctor and they say, it should be 28, well, it's really important that you've gone to them with a 46-day cycle. You think it's abnormal, so let's go and talk about it. If you were talking to your friends about it, they'd probably think, oh, that's pretty great that you get away with it so infrequently. So it's just something that we need to understand, that everybody is different, and that you need to know yourself as well as possible.
Yes. Do you see much delayed presentation in gynecological cancers because women have been afraid, embarrassed, unsure? It's a pretty hard area to investigate yourself, isn't it?
Essentially, we see that in about 70% of our women who have ovarian cancer is that they've got quite an advanced stage disease at diagnosis, because all of the symptoms of those cancers can be explained away as menopause or, endometriosis. And so they think, oh, well, I'm a woman, I'm in pain, I'm bleeding more, I've put on a bit of weight around my middle, that's just normal. I'm not going to go and see my doctor about that. So, we really need to encourage women that if they think that there's something wrong, if it feels out of the ordinary to them, then take it seriously. And the best thing you can possibly do is go to your doctor, have it investigated, and then go, no, it's okay, it's nothing, rather than thinking, geez, I wish I'd gone a year ago when I could have done something about it.
I think I'm just picking up on one of the things you said that is obviously going to be a pretty common one that can be normalized away, is the pain when going to the toilet, pain during urination. I think it's really, really useful for our listeners to go thinking about when the pain is occurring. So the pain, is it during the flow of urine or is it in the abdomen afterwards? Those are some of the subtleties that we don't talk about a lot, and they can mean they can mean very different things, can't they?
Absolutely. And on that point, pain during sex, is it in a certain position? Is it every time? Is it when your bowels open? Is it before your bowels open? Is it is it just during the month? Is it a particular week of the month? So knowing even those sort of things is really critical to help diagnose or help to lead us a certain way in diagnostics. And I think as women, I know I would be exactly the same. I think it was this week in the month, but I can't remember. I'll deal with it next month because this month I've got to get the kids to school and I've got to blah, 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 blah. I'm going to ignore it. And I think as women, we're very used to dealing with pain and dealing with bleeding and dealing with, getting ready to have kids. You've got 3 kids and, you've got to do things. And so you take the back seat all the time. And we've got to start prioritising our own health as well and taking note.
So the other thing that I'm picking up on is that I think that lots of people think, if it's a gynecological issue, it's related to my period or it's related to, But when you're talking about symptoms, you and Jessie have both mentioned urination. You've both mentioned, pooing or bloating, things that, again, people like, oh, maybe this is gluten or maybe this is something else. Like there's a clustering of symptoms that are all part of kind of leading to a diagnosis. So if I'm listening to this and I'm a bit concerned, or if I've got a relative who I know has kind of been clustering these symptoms, is a good thing to A, make an appointment to see your GP immediately, but B, maybe carry a notebook around and just take a note, say like, okay, it's day 7. I always get constipation the week before my period, and then I seem to get diarrhea with pain. And when I have sex, it hurts on the right-hand side, and this position hurts more than that. Like just to take note and to be present in that kind of moment, so that when you go to the doctor, you've got a kind of a full picture of what's going on.
It just made me think of Star Trek Captain's Log, keeping a captain's log.
But it kind of is like that though, isn't it?
And it does ruin the moment if you bring out a notebook during sex. Just like, hang on a moment.
A dictaphone.
But, like all jokes aside, like these things for busy women, particularly busy mums or busy career women, to be able to recall, even when was your last period, or for people who have a marina in and don't have a regular cycle, this stuff can just become a blur, so that when you're trying to talk to the doctor, it looks like you're pulling on intuition rather than actually this has been my experience over a period of months or years. But I think the big take home here is if you've got a clustering of symptoms or something is bothering you or you feel like something is wrong, you should go and see your GP, and then that person can make an assessment about whether or not you have to see a gynaecologist.
Absolutely. Yep, for sure.
So before we move on, I have now known of 2 separate people who have had cancer of the vagina or cancer of the labia majora, like cancer actually in the vagina itself. Both parties were very slow to go and get it investigated because of shame, because, it's one thing to have to tell family and friends you've got cancer. It's quite another, as I imagine it is for men, to talk about testicular cancer or, penile cancer. That's a whole different ball game. Is there something that we should also be aware of for abnormalities or swelling of the actual vagina itself?
So the problem we have with a lot of the gynecological cancers is that they're internal and there isn't a lot of, there's not a lot to see. So for breast cancer, you can feel a lump and we do the breast exams every month, but short of getting up in there with a torch, it's very difficult to be able to see inside the vagina. So it's really a symptom-led diagnosis. And so there isn't much that someone can do ultimately to determine that they have a vaginal cancer other than be alert to the symptoms. But as you say, they're very unusual types of cancers, and we'll talk about types of cancers in a minute. But you're right. I often think I feel very sorry for Farrah Fawcett. Now she won't care that I care about her, but she died on the same day as Michael Jackson, and so it didn't really make a blip. But she also died of anal cancer, and I think if she had died of breast cancer, it would have been all over the news and everything. But because it's a dirty word, you're not allowed to talk about anal cancer, and so I always felt sorry for her that it kind of got brushed under. She wasn't in the in memoriam at the Oscars that year or anything because we don't want to talk about why she died. And I think it's similar with vaginal cancer and with vulval cancers. No, it sort of seemed a bit distasteful and we don't want to talk about it. So I think bringing awareness to it is actually the first thing we can do.
And for our younger listeners, Farrah Fawcett was absolute beautiful model movie star in the 70s and early 80s, and she was one of the original Charlie's Angels, and the reason that I tried desperately to have flicks in my hair as a child.
Did you go blonde though?
No, I did not. I wasn't allowed to colour my hair as a child. But but you know what you're saying, we're talking in jest, but the shame and the embarrassment and the difficulty of having these discussions or going to see your doctor or talking to your partner about that, taking days, weeks, months to disclose this can really change the staging of a cancer, can't it? And then actually prognosis and diagnosis. So we are urging you that if you know someone, if you have a patient in the ward that is disclosing any sort of changes or worries, please seek further assistance.
Yeah, absolutely. And I think on that, these symptoms can occur at any time, and they can occur at any time of life. We know that precocious puberty starts as young as 8. So that's where it's, early onset puberty. And these things can go through right until the 80s and 90s. So this is a lifelong awareness that women need to have. I've had, high-grade serous cancer, which is a very much an adult menopausal sort of age, ovarian cancers diagnosed in women as young as 22, 23. So this is not an old lady cancer.
Yeah.
Old lady cancers.
It's a spread.
Yeah.
All right, so we're talking lots about cancers, and your number 3 are the types of gynecological cancers, and it'll be like all cancers. We'll have heard of lots of them, and then others we won't know anything about. Can you describe to us kind of at least, the more common ones and what they actually mean?
So we've just reached the end of Ovarian Cancer Awareness Month, so I'm really hoping that a lot of women and the men who care about them know about ovarian cancer. So ovarian cancer is one of the most insidious cancers we have because the symptoms, as we've said, are very vague: weight gain around the middle, potentially even weight loss, excessive fatigue, bloating, changes to bowel and bladder habits. So these are all things that can absolutely be explained away as anything else. So that's why they're often diagnosed quite late. Another one that probably people hopefully know about is cervical cancer. So we use the cervical smear test to diagnose that. And since the invention of the HPV vaccine, we've seen a significant decrease in numbers of cervical cancers, but that doesn't mean that it's been eradicated, and there is non-HPV driven cervical cancers as well. Another really one of the more common gynae cancers is uterine or endometrial cancer. The one that's probably less known is a fallopian tube cancer. So you can actually get cancer of the fallopian tubes, which is obviously the tube between the ovaries and the uterus. And actually, it's the fallopian tubes where the majority of ovarian cancers start. So we encourage women to have their fallopian tubes removed. If they were going to go in and have their tubes tied, for instance, you'd actually have them removed, and that would be a protective factor against getting the cancer, obviously, if it's not there anymore. And then going down, as you said before, vaginal cancer and vulval cancer are both HPV-driven, but separate entities in themselves. Then there's another one which is called gestational trophoblastic disease, which is actually a cancer that arises out of the placenta. And it's where basically a bundle of cells during conception goes wrong. Now, I won't profess to know anything about GTD because here at the Royal Brisbane we have internationally renowned experts in both the nurses and the medical field. So they take all of these gestational trophoblastic diseases for patients from across the state and provide support to New South Wales, Western Australia, Tasmania and everything. So they're amazing. So I won't go too far into that. But and there's a one final cancer that we sort of consider to be a gynecological cancer, and that's called a primary peritoneal cancer. And if you imagine that the inside of your pelvis is lined with wallpaper, essentially the whole inside of your abdomen is wallpaper. It's cancer of that wallpaper. And that's really difficult to treat because it's not one little lump that you can just pull out. You have to kind of remove the whole wallpaper. So that's a difficult one to treat. So they're the different types.
Yeah.
There's a lot rather than just thinking, ovarian cancer is the only one.
Yeah.
They're all treated differently. They're all diagnosed differently. They have different symptoms, but essentially all along that same.
They fall under the same umbrella of gynecological cancers.
Yes. And disordered bleeding, pain, bloating, that sort of thing remains the symptoms for pretty much all of them.
And I guess it's important to say that some people listening might go, oh my goodness, I've got bloating, pain, bleeding, and it absolutely may not be a gynecological cancer. But the big take-home message is if you've got a concern, if you're seeing a patient who is making those complaints, if you know someone in your family, for goodness sake, please go and see your GP and have a discussion.
Absolutely.
Us nurses are a weird bunch. We're very quick to diagnose ourselves and then not follow through on it and look after ourselves.
Yeah, I've had a brain tumour many times during my career. And so, yeah, absolutely. And we're also very quick to go, look, I've been under a lot of pressure. I'm really tired. My bowels have been off. I probably haven't been eating as well as I should have been. So it's all explainable. And if that's the case, then great. But better to do it up front than to go.
I wish I had of. Exactly.
Yeah. So, and I guess the one thing the one cancer that's not diagnosed through bloating and those sort of things would be the vulval cancers, which are almost like a skin cancer, but on the outside. And that usually starts with an itch or a sore that doesn't get better. So again, don't just treat yourself thinking it's thrush, or if the thrush treatment doesn't work straight away, go and see someone and actually have it investigated, because it is very difficult to get a good look down there yourself.
Yeah. Okay. All right. So your number 4, we're going to talk about gynecological cancers and risk factors for lifestyle. I'm imagining this is like all cancers, that you can be a really healthy person, do all the right things and still get a cancer. But there are some things that we can do to mitigate gynecological cancers or all cancers. Can you talk us through that, please?
Sure. The number 1 is stop smoking. It sounds a bit weird to say that your inside of your vagina can be affected by your smoking, but it is absolutely. So smoking is a risk factor for vaginal cancer and vulval cancer, and we just need to stop smoking.
Does that include vaping?
Yep.
I cannot believe the amount of young people that are vaping. So please
stop doing it.
Don't do it.
Let us be your mums and say, stop smoking. Absolutely. The second one is another one that we've heard 1,000 times is lose weight. So we know that endometrial cancer in particular is increasing because our weight is increasing as a society. So increased BMI is absolutely associated with endometrial cancer, to the point where if you lose weight, you can actually reverse your cancer. You can actually kind of cure yourself, because those disordered cells actually can repair themselves because they're not getting fed as much estrogen from your fat cells. So weight loss and stop smoking are probably the 2 biggest ones. Then there's other risk factors that you have no control over, such as the genetic risk factors. So the BRCA gene, we all know about Angelina Jolie having the BRCA gene, and she had her breasts removed, and she would have had a full hysterectomy, which would have included her fallopian tubes and her ovaries. So whilst BRCA tends to cause the cancers we think of as ovarian cancers, as I said before, they generally start in the fallopian tubes. So we would have all of that removed if there is a family history of BRCA gene. There's another syndrome called Lynch syndrome, which is also linked to gynecological cancers, more associated with colorectal cancers, but actually there's an increased risk in gynecological cancers as well with Lynch syndrome. So knowing your family risk, I guess, is really critical as well, so that you can go early and have regular screening.
So one of the things that you mentioned was around HPV and the association with gynecological cancers. Can you explain to everybody what is HPV and what can we do to prevent it?
So the human papillomavirus is a common virus that we transmit from person to person, and it can be essentially prevented by having a vaccine in our teenage years. Now, there are lots of different subtypes of HPV. So the vaccine doesn't protect against all of them, but it protects against the most common ones. And that then lowers your risk exponentially of getting HPV and transmitting it to others, and then of getting one of these cancers that is actually driven by this virus.
All right. So we've talked about what is gynecology, what are the symptoms of gynecological cancers, what are the types of cancers, what are the risk factors in your lifestyle for cancers? And so I guess this all leads us to, what are the treatments? Like, how dangerous are these cancers? Why is it important that we are so diligent about knowing our own bodies?
Yeah, so treatment is always as a combination of treatment options. So in gynae cancers, we use chemotherapy, radiation therapy, and surgery, generally in a combination of at least 2 of those things. Chemotherapy up front is often given for the sort of internal cancers, so the ovarian cancers, because we need to shrink the cancers to make them more amenable to surgery. So if you imagine that you got a bit of mold on your bread and you just cut out that tiny little bit of mold, that'd be easier than if the whole piece of bread is covered in mold, where you'd have to try and slice the whole top off the bread or something. I mean,
You're really good at metaphors.
I was just about to say, I think
And food conservation.
yeah, exactly. I would not just throw the bread away. I would slice the top off it. So then we would give chemotherapy to reduce the size of, I'm going to keep going with it. I'm going to roll with it. We're going to reduce the size of the mold. We would give chemotherapy to make it smaller, which then makes the surgery more effective and easier. It also
faster recovery.
That's right. And also more likely to be effective because we know that at any time that particular cancer could shed cells and set up camp somewhere else. So we want to try and avoid that if possible. So we give chemotherapy to shrink it, and that's called neoadjuvant chemotherapy. So neoadjuvant meaning we're going to give that first. Alternatively, we might do surgery up front, and then we might give chemotherapy afterwards to potentially mop up any of cells left behind, and that would be called adjuvant chemotherapy. Usually it's the same combination of drugs, but it's just given in a different sequence. We also use radiation, but we usually use that after we've done surgery because, again, if you imagine cutting into really burnt toast, it's harder than if you cut into bread. So radiation essentially changes the texture of the tissue, so we don't want to cut into that after it's been radiated. So chemotherapy and radiotherapy are given together, so not exactly at the same time, but say on the same day. For women who have cervical cancer, they'll have chemotherapy every day. It actually sensitizes the cells to the radiation, and the radiation makes the cells more likely to die from the chemotherapy. So we use them in combination. And there's also all the newer treatments like immunotherapy and hormonal therapy, molecular therapies. So there's lots of different treatment options, and they're really based on what the cancer looks like at a pathological level. So whether it's a high-grade cancer or a low-grade cancer, high-grade cancers tend to be more aggressive, but they often respond quite quickly to chemotherapy. Low-grade cancers are usually more slow-growing, but then because they're slower, they actually don't go through their mitosis, getting to a technical thing here, but they don't go through their life cycle quite so quickly, so they don't absorb and retain that chemotherapy as effectively. So it depends on the exact subtype of cancer, where it is, and if there are any other organs around it, will determine what kind of treatment the person has.
And how dangerous are gynecological cancers? Are these the sorts of cancers that lots of women recover from? I don't know if that's too hard a question to answer, but I guess if I'm trying to create an urgency in our listeners and a diligence in our nursing staff to pay attention to people who are describing these symptoms, how dangerous are they?
So it depends on the type of cancer. So if it's a cervical cancer and we've caught it early and we can do a radical hysterectomy and remove it, then the chances of long-term survival are excellent. If it started to go, I'm going to do food analogy again, but if you imagine a watermelon, because everyone can picture what a watermelon looks like, if the cancer was in the pink part and we just cut the whole thing out, then you've got a really good chance of long-term survival. So if you imagine that the endometrium or the uterus is like a watermelon, you cut the whole thing out, throw it away, and it's done. Whereas if that cancer had gone all the way through to the white part or even to the green on the outside of a watermelon, then that means that it's potentially starting to escape from that area. So you might need to do more extensive treatment, and that might mean that they're less likely to survive in the long term. So ovarian cancer, because it's often quite late to be diagnosed because of the vague symptoms we've spoken about, and because it isn't terribly chemosensitive, it can be quite lethal. So it depends on the type of cancer, where it is, what the subtype is, how much it's spread. But on the whole, they are notoriously difficult to treat and can have some really poor outcomes. Unfortunately, we look at a 5-year survival in overall gynaecological cancers of being about the 40% mark.
Wow. And this might be a dumb question, but if you've had a hysterectomy, does that dramatically reduce your chances of getting a gynecological cancer?
So a hysterectomy at its the exact terminology means a removal of the uterus only. So if you've had the uterus removed, obviously you can't get uterine cancer, but you could potentially get a cancer in any of the other organs that are left behind. So as I was saying earlier, a lot of the cancers actually arise from the fallopian tube. So even if you were having a hysterectomy for, say, just heavy menstrual bleeding or endometriosis, we would still encourage you to have your fallopian tubes removed or have that conversation with the surgeon about having those tubes removed. if you were over, say, 45, maybe closer to 50, and you had terrible bleeding, we'd also encourage you to have your ovaries removed because, again, if they're not there, then they generally can't get cancer in them. That's not to say that there's not the potential that cancer had already started and we just missed it. But, yeah, if it's not there, you can't get cancer in it. Yeah. And that obviously the uterus, the very bottom of the uterus is the cervix. So if you have your uterus removed with your cervix, then you're not going to get cervical cancer. So a hysterectomy is certainly protective against all of those things because it's not there anymore. But that won't stop you from getting a vaginal or a vulval cancer or even that primary peritoneal, which is that wallpaper sort of style cancer.
Yeah, so just a reminder for people who have had a hysterectomy, any symptoms that you're concerned about still absolutely should be explored.
Yep, 100%.
All right, some really important knowledge and fact sharing today, and I'm going to try and summarise this very succinctly. So today we've been talking about gynecological cancers, and first of all, you spoke about what is gynecology. And basically you described it as the study or science of women's reproduction organs, and that it encompasses a whole range of things to do with women's reproductive organs, such as puberty, bleeding, menopause, your periods, infertility. And the big take home for me here was women need to know their own bodies and we need to understand what is normal for us. And so anything that's happening that is outside the normal and persisting and not for months and months and months, as soon as you recognise there's a problem, please go and see your GP.
Yep.
Number 2, the symptoms of gynecological cancer are a bit tricky because they could be described as anything else. But the big ones I heard were unexplained bleeding, persistent bleeding, heavy bleeding, bloating, problems with your bowel, problems with urination, problems with pain or pain during sex.
Yep.
Number 3 were types of gynae cancer. I'm not going to name them all, but the big ones were ovarian cancer, cervical cancer, uterine or endometrial cancers. But important to remember that you can get vaginal and vulvar cancers as well. Mm-hmm. Number 4 was talking about lifestyle risk factors and gynecological cancers, and you were so very clear was do not smoke, do not vape, do not smoke, do not vape, do not smoke, do not vape. And that is relevant to all cancers, but particularly gynecological cancers. Number 2, watch your weight. Be mindful of your weight. Have a healthy BMI. Again, that is all cancers, but particularly gynecological cancers. And number 3, there are genetic concerns, and if you have a family risk, please go and have regular screening. Don't bury your head in the sand around that. Number 5, you talked about treatment, and I guess, you said that on the whole, there'll be a combination of chemotherapy, radiation and or surgery, and it's usually always a combination of those two, sometimes a 3, and that sometimes, we're using radiation to shrink a cancer prior to surgery. And there are some immunotherapies and hormone therapies around as well, but it will depend on the type of cancer and, how progressive that cancer is as to how people will be treated. Liz, thank you very much for coming and talking to us today about gynecological cancers, a really important issue and one that we don't hear about often. So thanks for joining us on 5 Things.
Oh, thanks for having me.
Thanks a lot. And I'd encourage everyone to have a listen to a couple of companion episodes to this. The prostate cancer episode, there's a lot of overlap and good kind of spaced repetition about the treatments and similar lifestyle things, obviously with a male sex assigned at birth bent. And also the sexual health episode is a great one of an overlap and some awareness, I guess, around the lifestyle risk factors as well.
Would you include the breast cancer one with Trace McCurry as well?
Heck, why not?
Yeah. A plug for our own podcast.
It's like a great weekend right there. Listen to all of them.
All right. Thanks very much.
The Royal Brisbane and Women's Hospital 5 Things Nursing podcast acknowledges the Turrbal and Yagara as the First Nations owners of the lands we now tread. We pay respect to their elders, laws, customs and creation spirits. We recognise that these lands have always been places of healing, teaching and learning. We also wish to acknowledge the First Nations people of the lands of our global community and encourage our listeners to seek out, listen and learn from the knowledge held in your shared space. As well as all major podcast outlets, you can find us at 5thingsnursing.podbean.com. Please Please also subscribe and give us a rating on your listening platform of choice. This helps others find the podcast. And finally, if you'd like to connect with Liz or myself on Twitter, we can be found at LizCrow2. And for me, it's inject_orange. We would absolutely love to hear your thoughts, ideas, or feedback. Thanks for listening to 5 Things